worked together with many patients. For example, my own brother suffered from metastatic colon cancer, and with combination of both therapies, he's tumor-free since 5 years, and it's a very fascinating work. What he's doing is he's very open-minded, so give a warm welcome to Professor Vogl.
Dear Dr. Probst, I assume I should also go for English.
Yes.
It's a great honor for me to present our data and my experience, and also the collaborations. Unfortunately, to a smaller personal health topic, I was not able to come to Munich, which is my home city. So I know the place where you had been, or where you have your conference. I know very well. This had been a former mailing office, so I know that when I was young, I brought a lot of letters there. Okay, my topic today is interventional oncology, present, past, and future, and I want to share with you the data we have acquired in many years of these collaborations. Now we have to see that I can get into my second way. Of course, this is my topic. I'm working at a university center, so research is tomorrow's practice. So it's very important to know that only by research we can improve ourselves. If you see here, what are currently the main topics in oncology? Of course, it's the surgeons, we have the oncologists, we have the radio-oncologists, we have the interventional oncologists, and of course, there are many other groups dealing with that topic. And my topic here is among these areas where we go. The discipline of interventional oncology is a fast-growing discipline. We are training people from all over Europe and the world. We have meanwhile installed also simulation centers for hands-on procedures. And of course, there are now many procedures available for nearly every area where cancer can grow, in pancreas, in brain, or in others. Also, we think that in palliative care, we can offer for patients a lot of methods in order to improve their situation. Just consider fluid in the belly or pain, and in that area. I always like to show by Dr. Rice this diagram. I think what is important, if you consider treatment in cancer with metastasis, it's always important to differentiate, is the cancer currently an oligometastatic disease, which means you have some areas with metastasis. This can be done by sloughed cancer cells, or you have the systemic disease where a lot of cells are migrating and then going to all organs from brain to bones. So it's important to differentiate. And I think currently, at least in oncology, there's too less efforts, especially on the area of oligometastatic disease. And here, I think we can offer different methods. My first work I started already when I was a fellow in Munich, and we worked a lot on temperature increase. So we had learned that hyperthermia in any way is changing a lot of things, and I think during the meeting you heard a lot about the halted metabolism, the impaired DNA replication, hyperemia with an increased sensitivity to radiation or liposomal agents. The temperature we go is mostly higher than 50 degrees Celsius, which might lead also to a sublethal damage in the surrounding areas of the cancer. What method we can offer? We have one method where we can use angiography. You see here we have a robot system in Frankfurt where we can target nearly every vessel in every organ. You can do it under CT guidance, where we do a lot of ablations like microwave ablations or other techniques. And because of the high incidence of radiation in this method, we're also offering MRI-guided methods, especially for targeted biopsies or targeted methods. Let's start with angiography, which means we are addressing the nutritional vessels for a tumor, and there is only a list of different methods we can go. We can go for so-called chemoembolization, which means we bring in with a microcatheter chemical drugs directly to the tumor. We can just embolize, which means we can stop the blood flow. This can be nicely combined with hypothermic techniques, because then we are able to increase afterwards the temperature. We can perform just local chemotherapy, we call it chemoperfusion. We also offer techniques like radioactive drugs, which are specially prepared from a nuclear plant in Australia, and then they are put on glass spheres and injected. We can also do it the same in the lung. We call it chemoembolization. We can do chemosaturation, which means we block a whole organ like the liver and perfuse it. Or in prostate cancer, we can do prostate embolization, or also in the small pelvis. If we have problems during surgery, or patients have bleeding problems, then we are offering all these techniques: port, cava, fragmentation, lymphography, or especially in the breast, you sometimes have the problem that you can identify lesions in the breast which are hardly to see in ultrasound or in other techniques, and then, of course, these techniques can be nicely combined by taking a biopsy then from the breast or from the prostate, which we do quite frequently. If you look for the CT guidance, there we can do ablations like radiofrequency or microwave ablations, or we can do drainages like if you have patients with biliary problems or endoleak embolization. Of course, nowadays, patients have to be referred, and we have patient stories, and together with Mrs. Schneider from my department, we have a possibility that we can show patient stories. You can find them on our homepage, and so this is important. Or this colleague who had a long-lasting tumor in the bones, and with new techniques like radiofrequency ablation, we were able to help him and to pronounce it. The story of Dr. Bauer also showed that even in melanoma, we can achieve situations. So since 2018, she was free of metastasis, this patient, and I think what we are trying to offer is methods which are helping to locally control the tumor, however keep the life quality in an acceptable way. I think that's very important. Let's look at and start with the liver. If you have a patient and he gets a diagnosis of a primary or secondary liver cancer, it's important to differentiate. You should consider three groups. There are patients which are really oligometastatic. Like this patient, he had a solitary tumor in the liver, in the middle of the liver. So here, so far, if you send this patient to an oncology surgeon, he will say, I resect this. Might be also possible to do it locally, minimal invasive, like I will show you later. If you have patients with bilateral tumors, it's already group 2. Here, chemotherapy is currently the standard of care, but maybe later also local techniques might be considered. Or these patients which have, like you see here, a lot of metastasis, and they mostly will never become resectable. But I think it's important that we can help them by improving the local situation. Of course, you need guidelines. Here are, for example, the Barcelona liver guidelines, and it shows that at the very end there are many methods available. And the poor patient who is now Googling has a big problem, because he will find a group, they say, okay, you have a liver cancer, we do ablation. The other group says we do resection. One group might even say, maybe you're a candidate for transplantation. Or we do chemoembolization, or we do systemic treatments, or we only do best supportive care. And that's something where you need the groups, and you need a very good cooperation between the treating colleagues in order to find the right decision and not leave the patient alone. Let's look for the so-called intra-arterial therapies, like I mentioned. So we have two methods. We can, first of all, and this is unfortunately quite often the case, that we just do a salvage therapy. So the patients are referred to us if already systemic treatments failed, the situation became worse, and then we should try to locally control the tumor. Or the first-line therapy, which is also interesting. So we have patients who have very big tumors, cancers, and they're all together we can try to lower the size of the tumors and possibly maybe convert the non-surgical patient to a surgical patient. So at the very end, maybe it makes sense to cut everything out or to do ablations or to do stereotactic radiotherapy. If you consider liver or lung, you can do the so-called chemoembolization. This can be done as a conventional chemoembolization, CTAs. You can have small particles loaded with chemotherapy, or you can have degradable stock. So what is interesting on this technology is it's mostly a multi-drug therapy. So you can more or less mix everything together, but you need, of course, a lot of knowledge. You have to check what had the patient before, what chemotherapy had, and the good thing, it's repeatable, it's reversible, and normally also after permanent embolization, we can reactivate the vascular. And it helps also with the diagnosis. I show you later also an example. So we can improve the diagnosis of a primary liver cancer. We can also see this patient here, if you look here, a lot of tumors distributed, but if we get everything down, we can maybe even have later the so-called curative therapy if we combine it with ablation. And this again, we try then to convince a patient. So for example, here in a patient who had prostate hyperplasia and cancer, and so in these techniques with the embolization, we can lower the tumor and improve the liver quality. Also, what is important is not to give the patient the wrong hope. You know, this patient had a very high tumor marker. When you look at the liver here in the MRI, you might see some very tiny nebulous dots which are shown here, also under the surface of the liver. So the surgeon said, oh, no problem, we resected the liver because there's only here one tumor. Said, okay, let's look, let's test with the local chemoembolization how many tumors you have. And you see suddenly this is not a unifocal cancer situation. You see there are many dots, so this patient had already an advanced situation, and then he needs a regional therapy. Makes no sense to cut this part of the liver away when still a lot of remaining tumors are in the other parts of the liver. So that's very important by diagnosis. Or this patient was also sent to the surgeons, and you see here in the angiography a faint nodule here, maybe some nodules here. But if you look at the CT scan, you see it's very unsharp. This is not the typical enhancement of a hepatocellular carcinoma. These were only regenerative nodules. We performed an image-guided biopsy, and the patient was considered free of currently active cancer. Does it work? This was a patient here. I think Dr. Probst, you sent it even though it came also from you. A very huge liver cancer, a big nodule developing. It's nearly not to understand that this patient had not previous symptoms, but he came with a local pain, and you see there was also another tumor here. So at this stage, this patient was considered to be non-resectable. In oncology, they recommended some tablets like imipramine, or you can also take sorafenib in the hepatocellular cancer. So we decided to perform a regional downsizing, a chemoembolization, and you see here after 3 courses of TACE, the tumor is much smaller, and now we can either do a thermal ablation, what I'll show you later on, or we can send it back to the surgeon. But then he has a good prognosis, then it makes sense. Here, the surgery would have made no sense. So here you see some data from our publication together with Lencioni. What is important is what the patient wants to know, of course, how are my chances if I'm just doing a TACE? And here you see a lot of guidelines, and you see that normally without treatment, the primary liver cancer has an expected lifetime maybe of 16 months. With a CTACE, we can improve it. But of course, we want to select those patients where we suddenly see that we are able to achieve 36 to up to 45 months, or even have the patient for a longer time free of cancer. So we made a systematic review. The only thing to get those data is to look for meta-analysis. So we found 15 studies in more than 2,500 patients, and at the very end we could see that microwave ablation or radiofrequency ablation or surgery were equal. So suddenly we have equal situation in comparison to surgery. But what are good candidates? So we can easily treat in the liver cancer patients from 2 to 7 centimeters. If they are lower to 3 centimeters, surgery and ablation is equal. And we need several sessions, and at the very end we can also do then ablation, which I have shown you. There can be no presentation in oncology without survival data, and you see here, if you combine these chemoembolization with ablation, you see versus resection that we are nearly equal. Even there is a little higher survival in the upper curve, which you see here nicely. This is due because we have less morbidity and less lethality in comparison to surgery. But in order to convince the tumor boards and convince surgeons, it will take some time. There are also a lot of studies where single centers, where studies are compared, and at the end, in oncology, we always want to know what is the overall survival, how long do the patients survive, and secondly, we want to know how good is a recurrence-free survival. So for a patient, it should be also good to have 1, 2, or several years free of cancer, or recurrent cancer, and this survival is very important. And you see here that in comparison, that this combination of chemoembolization combined with ablation is better than ablation alone, and this is nicely shown in the overall survival. Let's look at einer Frankfurt data. Currently we have more than treated 900 patients with primary liver cancer. You see here a lot of recurrent tumors which were sent from other centers, and you see recurrence-free survival after 24 months is still 74%. And what you see, there's also 1/3 of the patients are palliative. So they had no real option, but they had pain, they had problems by the high degree of tumor load. There we can help. Of course, there's portal vein thrombosis or other factors. And here you look at the overall survival from Kaplan-Meier, and you see here after 5 years, if you take all these patients with primary liver cancer, we have a rate between 10 and 22% of the patients still alive. You might say this is not a lot, but in patients who are coming in a palliative intention, I think it's much better than doing nothing. If we call it neoadjuvant, just to explain you, neoadjuvant means that we have a patient who is not a candidate for resection, ablation, whatever, then we do a treatment, so in order to improve his situation. So neoadjuvant means we make him a curative patient, and you see here the survival is suddenly increasing to up the mean survival about to 5 years, curative. So these patients where we first treat them with a local technique and then go to other methods, they have even a better prognosis. And this is here the Frankfurt data, which we have seen here. Laser, about also 50 months, RFA, microwave, surgery. And you see, however, the best survival have patients if they get a liver transplant. This is a very limited number of patients. They should be not too old. They should stop drinking and drugs and whatever. They need very localized tumors. But if they survive, liver transplantation is a good indication. But as you know, in Germany we have a problem of donor. We are from a university, so studies are important, and so I show you some studies on primary liver cancer. And you see, for example, that we compare different techniques. Should we do embolization with lipaidol or embolization? You might say, what is this important? But it shows again here the case, what I showed here from this trial, it is possible. We can reduce such a huge tumor, we can reduce to a lower size. Let's go to the ablation, which means we want to show how we destroy the tumors. We can either do it by injecting chemicals, we can do radiation therapy, we can just ischemia, which means we block the vascular supply of the tumor. We can do thermal ablations. Here, recently also we included cryotherapy in our portfolio in Frankfurt. You do electricity treatment or focused ultrasound, the so-called HIFU technique. How does it work? Microwave is meanwhile the best evaluated technique for thermal ablation. It works here with dielectric heat loss. In a way, you also use similar techniques if you use hypothermia. The good thing with microwave, we are coming over the non-thermal effects easily to about 60 degrees, 65 degrees, and we can reduce the so-called heat sink effect. So the distribution of the destruction is very homogeneous. I show you an example from, I think you know this lady, from Mona Lisa, and if you do ablation, if you thermically destroy tumors, it's important that we want to have a most rounded lesion. Most of the metastases or tumors are round. So if you have here a nice young woman here, but if she's slim, but you see here that we have a problem with the outer part of the tumor. So if we enlarge here the Mona Lisa, you see this is a rounded lesion what we want to have. So we need the ablation zone round, predictable, precise. That's very important. And this is now possible with new techniques which we developed further. So the heat is coming from the tip of this microwave antenna and then homogeneously is distributing. Active zone, tumor, and vessel. And this is very important because nobody wants to have a tumor recurrence. We are worsening the prognosis of a patient if we have a recurrent tumor. And of course, in a tumor board, if a radiologist has a recurrence, it is again and again shown and will be discussed intensively. If you look at the following slide, it shows you the advantages of this technique. So we have a higher safety, and we can also treat meanwhile tumors larger than 3 centimeters, which helps us in order to find good indications. Here I show you an example of a typical patient in Frankfurt. So the surgeons operated his left liver, and not very soon later, the patient developed a new tumor at the border. Here you see this is the cutting edge of the resected liver, and there's quite a huge tumor, 3.5 centimeter. Before microwave ablation and afterwards, and you see we can exactly destroy the tumor. Of course, not an unrisky situation. We have the adjacent hepatic vein, the portal vein, but however, we were successfully able to destroy the tumor, and you see 1 year later. And that's very important. If you send those patients to another radiologist, they might say, oh, there's still a tumor. No, it's not a tumor. It's just a scar. And if you have the patient, what you see 10 years later, then the scar is nearly completely resolved. So it is important that in all liver tumors, or the same is for the lung, you need the safety margin. You know, if you see here the tumor, you see in the metastasis of colorectal cancer, surrounding vessels, and after ablation you see the big hole which is destroyed into the liver. And here one example of a patient with a long survival. The patient came here before laser therapy with a huge metastasis directly at the adjacent right hepatic veins. And you see here the same patient 10 years after laser ablation. Still there's a scar. So every year when he comes for control, somebody did an ultrasound, said, oh, there's a new tumor there. No, it's 10 years. And still a scar in that area. But you have to know these findings so that you don't miss in the print. So in colorectal cancer, we also have a big series. You see it's coming from the rectum or the colon. The local recurrence rate is 3.8%, which is okay. However, a lot of patients, 10%, are developing new metastases. So it's a chronic disease. Here the complications which are shown here, minor and major only 4.6%. We do nearly all treatments in an outpatient protocol. If a patient is not feeling well or develops problems, then of course we take him as an inpatient. If you look for colorectal cancer, it's different to the primary liver tumors, but you see that the median survival time is here on patients in Frankfurt about 3 years. If it's curative, it's going up to 4 years, palliative only 1 year, which is shown here. Again, you have to look at Kaplan-Meier. And in Kaplan-Meier, you see here that the curative patient, they have the best survival, while in the palliative situation, the survival goes down. But also in the palliative group, you see there are about 10% of patients. If you survive these 3 years, you have a good chance to further survive and not to get again a recurrence. Here again shown the data. I think I can slowly go over it. It just shows you that for the tumor boards, we have always to again check, and it's important, we want all our patients to have here in the red line. So if you refer a patient to us, if you trust us, we try to bring that patient in the red line, which is a quite good survival. The blue is a palliative one. Of course, this has also to be done, but it's lower. And you see here also in the liver metastasis, right to left liver lobe, there's not a big difference. So it depends on the experience of the people doing that. So we had this also in a study, we called it the FAST-1 study, and we analyzed liver metastasis colorectal cancer. And we wanted to know, here our study, which was published in 2009, that we have it all done in the guidelines. And this is something patients or you as a referring physicians or also people from homeopathic, it's so confusing because you have the ESMO guidelines or European consensus guidelines, and here a majority in former times was only on chemotherapy, but meanwhile also local techniques, a systemic approach is mentioned. Can we do the same in breast cancer? Yes, especially in breast cancer, there are some patients who really have a dominant liver disease, and here we performed a prospective study, including different drugs in order to prove and to see how this can help. I'll show you an example. A patient here with metastatic breast cancer, young patient, a good situation. You see here the nutrition state is quite good, but you see multiple tumors dominant in the right lobe, dominant in the left lobe, and also in the central segment. So there's still a big tumor load, which is shown here. And you see after 3 cases, we had been able to downsize the tumor. And then we can reconsider, should we do ablation? And for example, this patient was also done with hyperthermia immediately, always before and immediately after the chemoembolization. And I'm open for that because we have the feeling the patients are tolerating the treatments better, they are in a better physical and psychological state and by this. So you see, again, there are many methods in interventional therapy, transpulmonary, transvenous, and transarterial. And what I have shown you for the liver is meanwhile also possible to do it in the lung. Again, we have the tumor boards, and these are the techniques which I showed you for the liver, we can also do for the lung. So for the lung, we can also do cryo, RFA, laser, EIE, or microwave ablation. How this is possible? The lung is a little more difficult. You know, it's a space where the lung tissue is in, and so we have to consider that there might be also, can develop a pneumothorax if you puncture the lung. But with the new techniques, microwave ablation, you see here a huge metastasis here in the right lobe of the lung. There was also a smaller one on the left side, so primary resection was not a good option. So what we did, we went in with a probe. Then we performed the ablation. It looks a little chaotic here, but after the ablation, 18 months later, you see there's still only the scar. So we were able, with the patient in an outpatient basis, to destroy the tumor completely in that respect. However, the lung has some challenges, and I want to share with you a case that I treated, and I had to discuss a lot in my board, in the lung board, because I said it will not work. You see, and you look in the lung CT scan, and you see here, one lesion is lying here, and the other one is lying here, in that area. And so the question is, what is more dangerous? What do you think is more dangerous? Here, the one near to the heart? Or do you think, you see the one here, or do you think this is more difficult, or this one? Okay, I'll show you. So you see this lesion, I inserted the microwave probe, performed the ablation, and you see it 24 hours later, complete ablation. Critical is this one here. Why? Because as you see here, during the ablation, this lesion started to move. You know, always the lesion tried to escape my needle, so I had to go more and more centrally near to the heart, which was not easy. You see here the final end, however it worked out. The most easy lesion is this one here, because I can address it having the patient on the side, and this is ablation. Done all as an outpatient. What is the outcome? And you see here 2 years after, you see here 2 years after ablation that the tumors had completely destroyed. So in the lung we can do similar things like I mentioned in the liver. Even if patients have several lung tumors, we can do chemoembolization, we can do destruction by microwave ablation, and of course you need treatment. And this is maybe the future. So we have working with 3D glasses in these operation theaters, but still, so far, it's handwork. It has to be done in that. So the advantages of these techniques might be superior soft tissue contrast, expanding the possibilities. But still, I think it's always very important is the patient itself. He is in the focus of our treatment. The conversation with the patient is important, the conversation and the interaction also with you as the people and the colleagues referring to us. And here you see my goal to the future is that we have to develop new technologies to help all these increasing number of cancer patients. We need innovative interventions. And what is very important, we have to practically train. And I'm very thankful also Dr. Probst that he's initiating those meetings where people are gathering to help these cancer patients. And I'm very thankful that he invited me in order to show you what's going on. I know it was a lot of information I gave to you, but I have a busy email and a good homepage, so in case you have questions referring on patients or whatever, I'm always willing to help and to assist. If there are questions, you can either send me emails if the communication today is not so good. And greetings to my wonderful city of Munich, and enjoy the building. As I mentioned, it was an office building, so it became a very nice hotel. Very near positioned, and during the Oktoberfest, it's one of the most busiest hotels in Munich. Thank you for your attention.
Es gibt keine Patienten, es gibt keine Therapeuten, es gibt nur Menschen.